Good evening, everybody. It is an honor for me to be here. I want to thank Carlos Herras Palau for his kind invitation, David Warwick, the past president of British Hand Society, and Sue Fully Love, the new president, whom I known for many, many years since she was in Plymouth. I'm not bringing a lot of solution, but bringing a lot of question to this presentation. We are going to be talking about few of the things that in the literature maybe have a wrong name. And before we start everything, let's do a review of the anatomy of the long bone of the forearm. These are two different shape bone. The ulnar tend to be straight, while the radius tend to have a modified S shape. The radius have at the distal end a funnel shape, full of made mainly of cancellous bone for some reason. The both bones of the forearm are connected by three elements: the annular ligament, the interosseous membrane, and the triangular fibrocartilage. The radius and ulnar are connected at both ends by bicondylar joint, pivot joint, similar to the knee. But different than the knee, we have one condyle in each one of the bone that allows the pronate and supinated upper extremity. For that reason, we need to be very careful when we are dealing with any fracture of the forearm, because the majority of those are intra-articular fracture, meaning any fracture like Galeazzi or Montilla is an intra-articular radioulnar fracture, and they should be treated as such and do not accept any change, any angulation, because it's going to affect both joints. And then you are not going to have the proper axis of rotation from the center of the radial head to the fovea of the ulna. The radioulnar joint is not all that complicated. It's made of mainly two bones and a ligament. The two bones are the head of the ulna, that is a keystone of this radioulnar joint, have two articular surfaces, the seat and the pole, is convex, support the radius, and have the fovea a little bit eccentric to allow the insertion of the radioulnar ligament. The sigmoid notch is semicylindrical, a little bit shorter than wider, is concave, the insertion of the TFC distally, and rotate around the ulnar head. Before these two gentlemen clarified everything for us, that what we saw was that blob of collagenous tissue that we call the radioulnar joint. Then they clarified everything for us and found the elements that form the radioulnar joint, especially the dorsal and palmar radioulnar ligament that are the most important part of it. Professor Manuel Yusa from Barcelona provided us this beautiful dissection, that cut of the radioulnar joint, in which the three elements are there. The important thing is to see how the head of the ulna and the sigmoid notch are congruent, and the TFC is just a mass of fibrous tissue that, according to Larry Chigi from University of Florida, he found all those bundles in which they are organized. He also did some studies about the orientation of the fibers in the cartilage. This is a specimen dissected under the microscope by Professor Makoto Tamai from Tohoku University in Japan, and it shows the main insertion of the triangular fibrocartilage in the head of the ulna, most of it in the sigmoid notch and a little bit at the base of the ulnar styloid. Fred Eckestan and Carl Goran Haggard in 1985 did a beautiful work in showing how the radioulnar ligament works. But they show that the dorsal ligament stabilize the distal radial joint in supination, while the palmar ligament stabilize the distal radial joint in pronation. And there is a problem with the distance between the insertion of the radius and the ulna in this ligament, because they get closer and they're separated. Bill Kleiman from University of Indiana in Indianapolis, Indiana, he did a beautiful job in describing all the part of the radioulnar joint, the irrigation, the form in which the radio rotate around the ulna. But he agrees with Dr. Eckestein and Dr. Hager that the ligament where the volar stabilize the distal radial joint in pronation, and the palm and the dorsal stabilize the distal radial joint in supination. The arc of rotation are different for the sigmoid notch and the head of the ulna. There are some dissimilar arches, and for that reason, it's a very unstable joint. The stability of the radial joint really given by the ligament. Because we didn't agree 100% of the way those ligaments were tightened and loosened, the first study was done by dividing the radius and the ulnar, clearing everything out of it, and just leaving a ligament rotating them. So we asked Professor Rafael Acosta, who is a double qualified orthopedic surgeon and plastic surgeon, he also trained at KINEMATIC Hospital, to do a study together with Bill Nadd, who was the professor of biomechanics, the School of Mechanics at the University of Louisville. And they took a whole apparatus. A whole apparatus is a cylinder with a piston that distracts according to the tension increase in ligament. There's a displacement, and that displacement measures the amount of electron that can pass, and the oscilloscope will tell you the difference. And what they did was to measure that displacement every 15 degrees of pronation, supination of both ligament. And what was found was that the dorsal ligament was tight in pronation, while the palmar ligament was tight in supination. We had also Marcos Mazon and Fernando Levaro from Houston, Texas, and they did a study about those ligaments, and they found out that the dorsal ligament was tight in pronation, while the palmar ligament was tight in supination. And finally, Professor Vivian Lees, who started the interest of the radioulnar joint while in Louisville, Kentucky. To the left, you have what we try to do with TEC scan, and then on the right, what she achieved at the end after a few years in Manchester, a beautiful study that she did. And she found that the volar ligament achieved the greatest strain in supination, and the dorsal ligament achieved the greatest strain on pronation. Then we have a little bit later, in 2009, Jim Botang, and Jin Xu, who have two ligaments and separated. Well, we are not so good in that section to find out that those fibers are separated. There are massive amount of fibrous tissue together. And they came to the idea that we have the dorsal ligament, the superficial dorsal ligament, tight in pronation, while the deep volar ligament is tight on pronation, and the opposite happened in supination. As you can see in the pictures around here, well, there's not much that we can differentiate in this area about those fibers. So I don't know how you can measure the length of those fibers with any mean that is not measuring tension, because how you can measure the different fibers if you can really not separate them. So
Luis, we're not getting the sound of that.
Oh, I will need to unplug this one for a second.
Well, do you want to go back one slide and then just talk over it?
Yes, yes.
Okay.
Let me unplug this one here and tell me, Carlos, if you can hear now. To evaluate the distal. Can you hear now?
We need to
stabilize the ulnar with our fingers and hold the radius and the hand with the other hand and rotate around. First of all, simple range of motion, then abutment, and then check motion in pronation and supination. One thing that I wanted to show is in pronation, I cannot get the ulnar going dorsally, but I gain the radius to go dorsally, and look at that I'm moving the ulnar palmally, but it's the radius moving dorsally, because there is no such a thing as a crisscross tightening of the ligament. The ligament, the dorsal ligament get tight in pronation, the palmar ligament get tight in supination, and that's it. There is no such a thing, because if we have a crisscross tightening of ligament, I wouldn't be able to move the radius dorsally and see how the ulnar is disappear a little bit because the radius is moving dorsally. To evaluate. Sorry. Well, as you can see, I'm going back here, and I hope you can hear me once again. Can you hear me again now, Carlos? Carlos, can you hear me okay?
Yes, we can hear you fine.
Okay, so both ligaments are a massive amount of thickening of the triangular fiber cartilage. They are different, the dorsal and the palmar. The palmar tend to be thicker than the dorsal, and that's the reason why more rupture of the dorsal ligament than the palmar ligament. But both of them happen, and some of them, everything gets detached from the fovea, and the wrist, the radioulnar joint is totally unstable. This is a drawing done by Grace Bond-Asher, that used to be the artist in Louisville, Kentucky. And you can see in blue is the volar ligament, and in red is the dorsal ligament. The dorsal ligament in full supination is redundant because the point between the fovea and the most dorsal and distal part of the sigmoid notch are closer. And the palmar ligament is tight because the distance is increased there. The fovea tend to be eccentric, and this is a picture of a K-wire that we put for reconstruction of the radioulnar ligament. And to be able to see the position of this K-wire in completing the ulnar, you need to extend the shoulder and really rotate the ulnar through the shoulder, because if you bend the wrist, the only thing you can rotate is the radius. You cannot rotate the ulnar. Both Ebner and Palmer in 1982 and Eckstein and Haggard found that the pronation and supination is about 150 degrees in most people, that you need 9 degrees of abduction and adduction of the ulnar against the humerus to be able to achieve full pronation, full supination. If you sit in the bank in the lab in the ulnar and put the screws there so the ulnar cannot rotate, you cannot achieve full pronation, full supination. And the other thing is that as the radius rotate around the ulnar, there is a displacement, proximal displacement for supination to pronation of about 1 millimeter of the radius. That's the reason why in some cases in pronation, you can feel some abutment of the radius or the ulnar against the carpus. This is a study done by Graham King from Canada when he was still a resident in orthopedic. Very clever study. And he did was kinematic of distal radii joint. And these are some of the views. It's just CT scan of the whole range of motion passing from, in this case, you have the pronation. Here you have the supination and back to pronation. You can see how this is a listed tubercle. This is the ulnar styloid. And you can see how the ulnar styloid get closer to the listed tubercle in supination and get further apart in pronation. But other thing, the other thing to see here is this is the fovea here, and this is the insertion of the TFC. The distance here is very close, so there's no ligament, and we need to be a little bit more logic about what we say. If this distance is shortened, how on earth can the ligament get tight with a shorter distance? Well, I'm not very clever, and maybe I'm missing something there. So let's go back again. Let's go back again. This is the fovea, and this is the styloid, and some of the insertion here in this area in an eccentric or off-center wheel. So in neutral position, both ligaments are loose. If we move then to supination, the distance between the palmar ligament, sorry, let's go back here, between the fovea and the insertion of the palmar ligament, this is the listed tubercle here. As you are taking the picture from Graham King and section then to illustrate it. You can see how from here to here, the distance is shorter than from here to there. And that will happen everywhere. If we go now to pronation, once again, the distance from here to there is closer than the here from there. This is an illustration by Bill Kleiman about how the radius rotate around the ulnar, and as you can see the bone passing this area here, the ulnar rotate, the radius rotate around the ulnar, the contact between the ulnar head and the sigmoid notch decreases when you have in full pronation, it's about 10 to 15 degrees of contact, in supination about 20 degrees, in neutral position about 60% is in contact. Paul Robert Stewart from Newcastle, he did study with Dick Berger, with Ron Linshai and K9 Ann from Mayo Clinic, and they found that the ulnocarpal ligament and extensor carpionaris subsheath did contribute significantly to the distal radial joint stability. And then Mark Garcia, Alex Hughes, and Elizabeth Hager did some studies about the triangular fiber cartilage as a stabilizer of the radioulnar joint. And not only they found out that how important it is, but they find out also the innervation and the proprioceptive information that trigger the contraction of the pronator quadratus. That once again, Paul Robert Stewart did some study and find out that the deep head of the pronator teres stabilizes the ulnar proprioceptive information, contract there to give stability. About the elbow joint, well, it is a hinge that allows only flexural extension. That's all the elbow does, flexural extension. And not only for the humeral ulnar joint, but radio humeral joint both. The only thing they do is to go up and down, don't do anything else. The proximal radial joint have the lesser sigmoid notch, that is where the head of the radius rotate, and have the annular ligament to secure the position. Then they have a radial collateral ligament, accessory annular ligament, and the lateral collateral ligament of the ulnar lateral collateral ligament. Then the annular or orbicular ligament is a very tough structure that inserts a both end of the lesser sigmoid notch that maintain the the radius in position, also permit the radius to freely move from pronation to supination, and the cartilage of the head of the radius is different of that area that make contact with the lesser sigmoid notch and the area that not. And the area that do not make contact with the lesser sigmoid notch is if you put the forearm in full supination, then the posterior lateral aspect of the head of the radius doesn't touch the lesser sigmoid notch, and is the best area to do prominent fixation of the radial head when you have radial head fractures. Then you have a ligament that not many people knows about that is called the quadrate ligament of the news. he described that in 1854. It's a 11 millimeter long ligament, about 8 millimeter wide and 1 millimeter thick. And this prevents hypersupination or hyperpronation. If you divide that ligament, you increase the supination by about 10 to 20 degrees and the pronation by about 5 to 8 degrees. About 60% of the axial load of the forearm pass to the radiocapitellar joint, and that is the reason why you put a metal joint in this area against the capitellum, and the patient end up with arthrosis easily in that area. The radial head anatomy is important for the axial load, as I mentioned before. Stability to prevent valgus deformity. Also for posterior lateral rotational stability, and the most important thing is to prevent longitudinal instability of the forearm. If the radial head is not present, then the radius is going to migrate proximally, especially if the interosseous membrane have been damaged. The distal part of the head of the radius is the neck. Between neck and the shaft, there is an angle about 7 more plus or minus 3 degrees in the angle. The basipital tuberosity is at about 123 plus or minus 2 degrees in angle with the radial styloid, and the diameter of the radial head is about 22 plus or minus 3 millimeters. The average size of the bicipital tuberosity, that is important for those of us that like to drill hole to reinsert the bicep tendon when you have rupture, because it's more secure in that area. It's about 15 millimeter in width, in about 2 millimeter, more plus or minus 2 millimeter. About the anconius have been a lot of discussion about if it works or doesn't. And once again, Gray and King from Canada have done some work showing that really the anconius have a function on stability of the lateral ligament of the L. Well, because we tend to do a lot of things differently, we have separated now the radius and the ulnar distally from proximally. So we have now elbow surgeon and we have wrist surgeon. So who take care of the radioulnar joint that is at both ends? Our interest on this joint came because of big disaster. In Glasgow, we used to do a lot of data procedure, and we did that because we have patients like this one that have pain even at rest. By doing data procedure, the patient couldn't lift anything, but they couldn't lift anything in this condition. By cutting the ulnar head at this area, at least the patient will have not so much pain at rest. Couldn't lift anything, but they couldn't lift anything anyway. They were crippled. It's not like today that you have patients coming to your clinic with rheumatoid arthritis that you don't know that they are rheumatoid patients. They might come from somebody else, but they have a positive rheumatoid factor. So we did in excision head of the ulnar, someone with osteoarthritis was the biggest disaster. So we have some interest on radioulnar joint, and we had the privilege to have Professor Vivian Lees with us in Louisville. She helped us a lot in some of the studies of everything of the forearm with the people from the university, the mechanic department of University of Louisville with biomechanics and mechanics in general. And we put everything with computer that help us to do the function of the muscle. And then we use TEC scan to see the direction of the force. So we couldn't present this paper because we didn't finish on time and didn't have all the information. And most important, they objected that because we're putting some foreign material inside the joint. But remember that TEC scan is fraction of a millimeter in thickness. But anyway, that didn't work. And we were so lucky that Professor Vivian Lees managed to finish all the work done in Manchester. And the she found out that when you excite the head of the ulnar, you not only have problem with lifting, but you disrupt the axial forces passing to the forearm. We study absolutely every single muscle. We did that with Professor Ayer and one of Michael Boland that is now in New Zealand. And what I like to do with you all is to do an interactive exercise. And I want you, all of you, to help me, please. I'm going to disconnect here so I can stand, and hopefully you can see me. So what we did, we like to do for all of you is that you do me a favor. Let's put your arm extended, okay? The right arm extended. Put the left hand in anterior aspect of the upper arm, and then flex the elbow in neutral, and then supinate. And you see how the biceps came there. So the bicep is not working in neutral or in supination. So now let's do the other thing. Let's put the left hand on top of the right hand, and then we are going to flex the elbow. You can see now how the brachioradialis is contracting here. So now put your left hand on top of put the left hand on top of the tricep in the back, and try to flex the elbow by contracting the brachioradialis without finding the tricep. You're going to see that that is impossible, because indeed utilizamos el brazo derecho, la mano izquierda sobre el antebrazo en el frente. Flexionamos el codo y hacemos supinación. Y ahí vemos como el bíceps vino. Hacer es poner nuestra mano izquierda sobre el codo que está flexionado de la mano derecha, y tratamos de flexionar ese codo y vemos cómo se ve el brachioradialis aquí. Ahora vamos a poner la mano izquierda sobre el tríceps y tratemos de contraer el brachioradialis sin contraer el tríceps, y no podemos. Y sabemos que si contraemos el tríceps y el brachioradialis al mismo tiempo, tenemos con contracción, que es lo que pasa en la espasticidad. Well, that was for the people from Latin American joining us and from Spain. And you saw here how the biceps, you can see how the biceps is not working in pronation, but work a lot in supination. So in resume, we have the bicep brachia is first of all a supinator. And after supinate, then become an elbow flexor. That's what we're going to lift anything heavy. We put our hand in supination, that we can recruit both the brachialis anterior and the bicep working simultaneously. The brachioradialis is not a muscle that we can voluntarily contract. You need to have something pushing on it for that to contract. The function of the forearm is therefore very simple. In the elbow, the radius and ulnar go up and down, up and down. Then the hand is placed in position of function by the radius that rotate on top of the ulnar. There are a lot of important muscles here. The last three muscles are mainly a stabilizer of the radioulnar joint. The forearm has two functions, two compartments, and one of those compartments is handling the axial load. The other is forces against gravity. What about how does it work? Well, in this position, we have the axial loading passing from the hand, the carpus, the distal radius, and passing all the way to the capitellum. The forces against gravity pass from the hand and radius to the head of the ulnar, there from the trochlea all the way up. In this case, the ulnar is supporting the radius actively because the brachialis anterior is flexing the elbow. In this case, the radius is being riding for free on top of the ulnar, and the lifting is done by the deltoid as the humerus have the ulnar locked in the elbow. The rotation of the radiocarpus, the low transmission of the joint passes, what I mentioned before, from the radius all the way to the capitellum. Some of that passes to the trochlea as well. Recently, we have a paper in 2011 in which they show 3 different joints in the forearm. One is the proximal radial joint. The middle is the interosseous membrane and the central band, and the last one, the radioulnar joint. Well, there's a paper before that was published by Scheker, Palmer, Werner, and Fontino, and they found when the radial head is intact, very little of the forces are passing through the to the central band. When the radial head is excised, all of it passes to the central band. So what is the function of the interosseous membrane? Some of the people also talk about the interosseous membrane stabilizing with the dorsal oblique band. And this dorsal oblique band was described a long time ago, and then Noda revisited that. And then Hisao Marimoto also did beautiful dissection. But what happened? Only 40% of the specimen have this band. So what happened with the 60% that doesn't have it? The other thing, those people that have the band can be from 0.5 millimeter in diameter. What can stabilize when the amount of force is passing to the radio and the radioulnar joint are so much? But that's not the thing that we are presenting as argument for all of you to illiterate me, because I have no clue about this. The truth of the matter is boxers tend to pronate when they hit. And if you have someone like Fran Bruno could generate 1,420 pounds when he some blow in somebody's face, enough to create 53 Gs. It's 53 times the force of gravity. And so the interosseous membrane helps to dissipate the axial loading. How does it do that? Well, with the force, the axial loading coming through the radius, and they find resistance in the capitellum, and the radius might be inclined to hyper bend, the hyper arc. Well, the interosseous membrane that have fiber coming from distal to proximal to the most prominent area of the curvature of the radius, and from proximal to that particular area. So what happens is prevent that and dissipate some of the force, and this force then pass to the trochlea as well. If we don't have everything stable, we can have, if we remove the head of the radius or we remove the head of the ulnar, we have instability. The transverse instability can happen if we do those by distally, the radius falling on the stump of the ulnar, and proximally, the radius touching the ulnar proximally. The longitudinal instability comes from not having a radial head, not having a very good triangular fiber cartilage, and ruptured interosseous membrane, because in those cases, then we have collapse. If we had the 3 joints, as have been proclaimed, then it's like hinges on the joint, on the door. If you have 3 hinges on the joint, you can take any one of those and continue to work. In this particular case, we were forced to take the middle, take all the interosseous membrane tissue, because this patient have a burn and have ankylose between the radius and ulnar. And that's his full pronation supination in the left upper extremity. Well, we went ahead with, thank goodness, they put very good flap there. We split the flap so we can have some fat to put in between, excise all the tissue there, and then the patient now have pronation supination and a stable forearm, because the distal radius and the distal radial joint, the proximal radial joint were stable. About excision of the ulnar is long time that it started. We Claude Bernard and Charles Wett, when in 1851 they wrote a book in French called Illustrated Manual of Operative Surgery and Surgical Anatomy. And since then, everybody came and did something. First of all, Dara came in 2012. Then Mehmet Kapanji, who have probably read the work of Baldwin. Baldwin found that in those ankylosed radioulnar joint, if you take a little segment of the metaphysis of the ulna, you can pronate and supinate again. And then he decided to do the arthrodesia at the same time of the excision, the more fragment, and became a name that now everybody talk about Sobe Kapanji and is still doing them. About ulnar head dislocation, what do we know about that? Well, Dara talk about anterior dislocation of the head of the ulna. But it happened that the ulna is articulated to the humerus, and there is no rotation there. The ulna is the only stable part of the forearm. The radius rotate and is not connected, fixed to anything in the humerus because the radial head rotate, and as the radial head rotate, there is no anything to stabilize that, like the hinge that you have with the trochlea. What about the ulnar stump instability? Well, does not happen either. Once again, the brachialis anterior is that the muscle that flexes the elbow all the time and insert distal to the coronoid process of the ulna. Therefore, it's the only flexor, and the ulna goes up and the radius fall on it. And that's really what happened. We didn't learn from Milch that sometime in 1941, he saved a child, 17 years old child, from having a painful impingement by doing a cuff excision of the ulnar, the collis fracture. Well, rather than following Dara and everybody doing Dara, we should have been doing this procedure in many people doing ulnar shortening. It's a great procedure. So today we have many people doing these procedures. One of my papers I published in Australasia was about why it was important to preserve the head of the ulna, and it was rejected because we criticized Professor Watson. And one of the reviewers said, who the hell is this guy to criticize Professor Watson? Well, the truth of the matter that if you take the radial head, the ulnar head, the radius is going to fall. And that was shown, first of all, by Bell, Hill, and McMultry in 1985. And then with Professor Vivian Lees, we showed the dynamic part. It's so easy to do in the clinic. Just ask the patient to lift a little bit of weight and have an X-ray taken with a cassette between the body and the arm. And you're going to see that doesn't matter what is done. They all have impingement because the radius is going to fall on the stump of the ulna. Doesn't matter where you cut it. If you take the radial head, you're going to have proximal impingement because the supinator and anything else is going to make the radius fall onto the ulna. And cases like this, you have in ulna very plus. And the reason for that is this is a case of an excelopresty. The radial head was excised, so the radius continued to collapse proximally. And the only thing that do not allow the radius to collapse any further is because the head of the ulna is supporting in this to the carpus in this area. This was a very clever individual from Birmingham Accident Hospital. In 2 cases, he did the description of the rupture of the diaphragm cartilage, the dorsal membrane fracture of the radial head. There are people that have made our life very difficult because we were happy camper doing ulnar a radial head excision, or radial head shortening, or ulnar shortening, avoiding radial head excision. And then Lucas Smith and Fabry show us that not every sigmoid notch was equal. They had different angulation. Well, whom else make our life difficult? Well, Tolat, Stanley, and Trail, because they show that the sigmoid node has different shape. And what is that important? Because it's important if we are going to do ligament reconstruction, if we are to design an implant, anything, we need to have these two papers, because these people try to make our life difficult. Another, Mr. Tollard is present there, and we are very grateful for his work, because that clarified a lot in cases that didn't do as you wanted to do after you repair the ligament in those areas. Finally, stabilization of the ulnar stump. There are a lot of written about that, but stabilization of the stump is like asking the flag to stabilize the pole after we cut the pole. The ulnar is the support of the radius. How can we support the radius? By taking a tendon that insert on the hand that is supported by the radius to stabilize the stump of the ulnar. Well, the thing is, so thank goodness we have moved a little bit forward. Now people understand a little bit more that it's the radial joint. And these are all papers talking about stabilization of the ulnar stump. And I didn't put all of them because about 123 papers talking about stabilization of the stump. And they talk about reducing the pain, the same way they talk about the pronation supination after ulnar head excision. Well, the paper that is good to read is about Dick Berger, Kainan, and then Lawrence Berglund, Michael Kahn, and Michael Xavier, both, all of them from Mayo Clinic, and they talk about stabilization, putting a prosthesis when you have ulnar head excision, and that prevented the impingement. Palmer did a beautiful description of all the damages you can have in the triangular fibrocartilage. And then Bill Cooney, Ron Shai, and Jim Dobbin synthesized those into 4 types. Those that were degenerative and those that were traumatic. Degenerative, we knew about those long time ago because Misek in 1978 talked about the perforation of the disc of the triangular fibrocartilage that start in the 3rd decade of life and then increase continually. By my age, probably I should have holes everywhere. Then the traumatic one, I don't know how anybody can create this little bottom hole in this area. The truth of the matter, it came from the periphery. And the periphery have blood supply, as was shown by Turopati, that about 20% have blood supply in that, and therefore the periphery can heal. But the periphery can heal in a stretched position, and that is part that make it incompetent, because any ligament that you stretch by about 10 to 15% is not a good ligament any longer. The attritional injury already is related to age. Positive area should be radial, negative area, because really the radial sometimes a fracture, whatever, is become negative, or the ulnar have no change at all, or because chronic ulnar kappa abutment, also because of the radius might be shorter than normal. There is a lot of having written about the abnormalities. Those are symptomatic, asymptomatic, and that Jimmy Chang with Tunis and David Ring, they published fantastic work about how it increases in the other people, and how there can be lesions that are asymptomatic and lesions that are symptomatic. One of yours, surgeon, John Stanley, have been fantastic in everything. He understands the forearm more than most people. And he wrote about the stability of the distal radial joint, as the instability was the inability to maintain normal anatomical relationship of the radius on the ulnar, on the physiological loading, and with the normal range of motion. And this is the truth of the matter. If you don't stabilize those joints, the radial the radio is going to be slipping back and forth on the ulnar head, and it's going to denude, take all the cartilage from the head of the ulnar. In many of those cases, end up as an ulnar head excision, and ulnar head excision with all the problem. So we are going to talking about what is tight pronation, what tight supination. Let me show two cases just to show what is going on there. This is a patient of dorsal instability, and in this case, what we're going to do is to reconstruct the dorsal ligament going from the both dorsal and distal part of the sigmoid notch to the fovea. And not like Adam copied this one. Adam published his work in 2002, and it's a poorly done technique because it's not anatomical. A ligament to work need to be in the direction that the original was. You cannot recreate ligament the way you want. To be able to have stability, the ligament need to be tight and short. So this is what we're doing, going between the second and the fourth compartment, the radius where there is nothing there, and between the fifth and the sixth compartment on the ulnar side. And we just showed before how we find the fovea, and then by hand we drill to create the tunnel, and that we end up with some tunnels like that. Why do we do that? Because it's better. We use the locking that, this screw doesn't give us the same tightness that we need. So we create those tunnels. We pass a spider made of wires, and then take a tendon. If we don't have the palmaris, we take the palmaris longus. If not, we take a toe extensor, because you don't have the palmaris longus, probably you don't have plantaris either. Then we pass the tendon inside the joint. Then once inside the joint, we pass it inside the bone. With those lupus wire, we fix the ulnar side first, if it's the dorsal, because as we rotate in supination to tighten the ligament and lock the ligament position, then the part here in the ulnar is going to disappear. We're not going to be able to see it. And then at the end, we fix the ligament to itself, and that's the patient pronation, supination, no problem, no instability. This ligament, was attempted to be published, but it was so long that they gave us 8 pages. The dorsal part was described. The palmar part, they put that this technique can be modified to the palmar. And to the palmar aspect, you can see now a prominent ulnar, but the ulnar is not subluxating. It's the radius are falling dorsally, and the ulnar is look prominent because the radius is falling. The dorsal ligament, the palmar ligament is gone, as you can see there. And if you supinate completely, you have the empty sulcus as the ulnar is maintaining position, but radius is falling dorsally. So the ligament now go from the most palmar part of the sigmoid notch to the fovea. And once again, the only thing we need to do is to do one more incision, and that is the palmar incision. Need to be careful to protect the ulnar artery, ulnar nerve, and the medial nerve how you are drilling, because you're going to make a little capsulotomy, and then by hand you're going to drill, passing everything in the right direction. You can see here how you're going from the sigmoid notch distally and to the radio palmally, dorsally here, from the palmar to dorsal, and then you can pass the tendon that have the same position there. Then you tighten everything in the dorsal, and at the end you have a patient with full pronation, full supination, and you don't have the radius falling dorsally. So we are very fond of ulnar shortening, because you can change the contact between the radius and the ulnar in many of those cases, and extend the life of the radioulnar joint, because in those cases you can change the contact between the radius and the ulnar. You can tighten the ligament, and that can prolong the life of the joint. To finish, the radioulnar joint allow full pronation supination. We need to pronate everything. If you have good pronation supination and you have a fused radiocarpal joint, you function very well. If you have good radiocarpal joint, but you don't have a good radioulnar joint, you don't have the same function. So it's important to stabilize the distal radial joint, the proximal radial joint, and the architecture of both bones. With this one, we finish